everyone. Welcome to today's Global Grand Round. Aisha, and I'll be your host for today. So before we start, I'd like to go over a few things. This presentation is going to be recorded and uploaded to our YouTube channel. On Zoom, you may turn on a feature called closed captioning during the presentation to allow for subtitles. Please also create a Figure 1 account to collaborate with other medical professionals. If you have any questions about this, please let me know. I've provided all relevant links in the chat, and now I'm going to hand it off to Dr. Pecchia, who will be introducing our host today. Thank you.
Thank you, Aisha. Welcome, everyone. I'm Dr. Gregory Pecchia, Volunteer Medical Director at Global Offsite Care, and for past 3 years have also been leading with our volunteers, including Aisha, this morning on these monthly Global Grand Round sessions. Thanks to all of you for your interest and engagement over the last few years. And this morning, we're honored to have a return speaker. Welcome back, Dr. Timipre, or Timipre. Dr. Timipre is a pharmacy doctor and a dedicated member of the inpatient unit at the Department of Pharmacy at Federal Medical Center in Aghogho. She serves as a consultant clinical pharmacist and as a distinguished fellow at the West African Postgraduate College of Pharmacists, with specialized expertise in critical care and nutrition pharmacy, a field that demands both precision and commitment. She brings a high level of clinical acumen to her practice. Dr. Timipre is also actively engaged in global healthcare education and research, contributing to the advancement of pharmacy practice beyond borders. In this presentation, she will discuss the vital role of antimicrobial stewardship, a coordinated approach that promotes the responsible use of antimicrobials, including antibiotics, and enhancing patient outcomes and combating resistance. So with that, again, welcome, Dr. Timipre, and I will hand the meeting over to you. There will be a Q&A to follow. Aisha will lead on that. And again, we appreciate you being here today and looking forward to your presentation.
Thank you so much. I appreciate it. I'm happy to be here. I want to be talking today about antimicrobial stewardship. It's a critical responsibility. I'm going to be tailoring it to recognizing pharmacists' contribution to antimicrobial stewardship and to emergency response. Like we said before, I am a pharmacist and I work in the inpatient pharmacy unit of the Department of Pharmacy, Federal Medical Center in Aghogho. Okay, so I was talking about the overseeing the use of antimicrobials to ensure that the antimicrobials are safe and also effective. And the antimicrobial stewardship actually is a coordinated program, and it promotes the use of antimicrobials, like I talked before, including antibiotics. Now, we want to improve patients' outcome. Patients does not belong to any particular healthcare providers. We have the physicians, we have the nurses, we have the pharmacists, the physiotherapy, and then all that. We work in collaboration to help to improve patients' outcome. Now, at the end of the day, we want to reduce any microbial resistance, we want to decrease the spread of infection that are resistant. Now, I'm in the hospital setting, and I'm talking about the hospital setting as well. Now, what is the importance of antimicrobial stewardship in the hospital? Why are we talking about it? Now, I want to reduce the risks of antimicrobial resistance, we want to improve patients' outcome, we want to ensure that the antimicrobial that they are taking is safe and is also effective. We want to remove unnecessary antimicrobial use. This happens most times, especially when the patient is in coma, they will give it enough of antimicrobials. We want to reduce all that, and at the end of the day, improve patient's outcome. Now, what is the role of healthcare professionals? I've said it before that the patient is not a particular, the physician don't fund the patient, the nurses don't fund the patient, the pharmacists don't own the patient. It is a collaborative effort among everybody that is involved. Now, when it comes to antimicrobial stewardship, we are talking about the microbiologists and the infection control specialists. These persons, in collaboration with the physicians and also the pharmacists, have to work to make sure that the patient gets optimal. Now, there are evidence-based practice and also guidelines. We have to implement it. Some of them based on experience, some of them based on records. Then educating patient and also staff on the appropriate antimicrobial use can also help. So the healthcare providers have, the picture I have there is just a collaborating effort with the pharmacists and other healthcare professionals discussing or seeing way forward for a patient's outcome. Now there are goals. Antimicrobial stewardship, there are goals. We have to ensure that the right antibiotic is used at the right dose and also the right, duration. And this will mean that you are optimizing antimicrobial therapy. We want to minimize the development of resistant organisms through responsible use. And that will also mean that we are reducing antimicrobial resistance. We want to improve patients' outcome. I've talked about it before. We have the clinical outcome. We have the economic outcome. We also have the humanistic outcome. All this will reduce mobility, mortality, even the length of stay. Patients wouldn't have to stay long in the hospital. They want to minimize the adverse effects. We have some organisms that do well in the presence of antibiotic. And that's an adverse drug reaction. So we want to minimize it. Don't want that to happen. They also promote cost-effective therapy. There will be a situation whereby they have to use the antimicrobial in a way that minimizes benefits while maximizing benefits while minimizing costs. You get the same result, but it doesn't have to be expensive, and it gives you very much results. Now, there are key components in the antimicrobial stewardship program. For it to be very effective, they have to build an effective antimicrobial program. And we have what they call the leadership commitments. In fact, that's the number one. If that is not there, it won't even work so well. I'm talking about the hospital setting here. There has to be support from the hospital administration and the leadership of the hospital. And they should also set up a multidisciplinary team made up of not just the physicians. We have the pharmacists, we have the microbiologists, we have the infectious disease specialists. Then I talked about guidelines, protocol that are there. We want to look at it, update it, and if there is no, we want to develop it. Then there's also education and also training. It has to be regular. And if there have been a training before, they have to be retraining. Definitely. And then we have to get monitoring and also feedback. We want to find out what we're giving, how is it, we want to track their use and provide feedback to prescribers. Because in the hospital setting, the physicians prescribe while the pharmacists dispense. So this is very, very important in order for it to be successful in the hospital setting. Now, there are strategies for effective antimicrobial stewardship. You know that antimicrobial resistance is a global crisis because my first slide also showed why we need this antimicrobial stewardship. That one is trying to tell us why we actually need it. If you look at it, I have a report that is showing, although it's a 2014 report, it's a review about what's happening globally. The deaths attributed to antimicrobial resistance every year by 2050. If you look at that report, you'll see that Nigeria has the highest with 4,730,000, followed by Africa closely by 4,150,000. Then the smallest is Kenya, and that's because of their population also. So the deaths attributed to antimicrobial resistance is of serious concern. So that's why we should look at it and then see the patients as not just one healthcare provider having it. It's a collaborative effort. When we do this, we'll be able to reduce deaths. These have been predicted for 2050, antimicrobial resistance. We're talking about the strategy for effective antimicrobial stewardship. There is a WHO aware tool that can help countries to tackle it by looking at antimicrobial use that should be used. And WHO have gone as far as categorizing. We have the access, we have the watch, and we also have the reserve. Now, the access, it should always be available. They are like the fourth line. They should always be there. But the watch, they should be used sparingly, not all the time. And as for the reserve, only as a last resort. It shouldn't just be the number one thing that, they should use. So antibiotic approval and registration policy, the implementation helps to ensure the appropriate use of restricted antibiotics. And then adjusting therapy based on cultural results to narrow the spectrum of coverage. I agree that in cases of emergency, the patient can just be rushed in. Probably the patient is not talking at that moment and all that. And then you can't get information. Then based on experience, the physician can just give what that can help based on experience because they've seen those kind of cases in the past. But when microscopic cultural sensitivity test is later carried to results, in order to narrow but we use this drug, and even though it is at the reserve, it works. Yes, it's true. It can work. But we're talking about resistance here. We don't want a situation by patients who come down and when they really need those drugs for other more very, very emergency things, it will not come up. Then for the access group, we have drugs like the amoxicillin, ampicillin for various bacterial infections, the ceftriaxone for bacterial infection, even the meningitis can be taken care of. Then we have the ciprofloxacin, we have the doxycycline. Those ones are on the access list. But for the watch list, we have the azithromycin, used for respiratory infection. We have the clindamycin for respiratory infection, the H. pylori infection when it comes to ulcer. Then we have the fluoroquinolones, basically the levofloxacin and the moxifloxacin. Then we have the cephalosporins, the cefepime. Okay. You look at the one, therefore, there is resistant infection. Then we have the polymyxin B for multi-drug with resistant, and also the carbapenems. Those ones like the meropenem, they are to be used as the reserve. And most especially, we can say that because important consideration for them, we consider that you have to monitor them, especially talking about the cholesterol now, you have to monitor it due to the potential toxicity it can cause. And for somebody who has renal issue, if there's any renal impairment, they have to do a lot of therapeutic dose monitoring because those things have to be adjusted. Don't just give that. The same also goes to the carbapenem. So there are sometimes you have to switch from IV intravenous to oral antibiotics. Yes, when it has been observed that this patient is getting better, this to reduce complication and also reduce costs. But especially here in Africa, most of the antibiotics that come in the intravenous, they are not cheap, they are very expensive. And sometimes you have to give doses for a long time when the patient is stable. But when you switch to oral, when the patient can actually take, it can reduce costs and also reduce complication that comes with giving intravenously. Pharmacists play a serious role when it comes to antimicrobial stewardship. This is just a picture of them because section of pharmacists in my facility. So pharmacists can work with other healthcare professionals. They don't work alone. They don't work in isolation. They work with other healthcare professionals and they review and optimize prescription. They review antimicrobial prescription for appropriateness and also provide recommendation. They provide recommendation. They provide education, not just to the profession, not just to the patients. They also do that to other healthcare professionals. The patients may be at the bedside needing attention. You find out that the physician, apart from the physician comes to see them, the physiotherapy also comes. The dietitian also comes. The pharmacist also comes. So it's not just one person. So they work with others to make sure that the patient gets the positive outcome and improves the patient's quality of life. Now, implementing a monitoring protocol, pharmacists help to develop. They assist to implement. They also help to monitor antimicrobial protocols. That simply means that if there's any antimicrobial stewardship in any hospital setting, pharmacists should be in that team. Now, collaborating with other healthcare professionals, they work closely, like I have said before. It's just to optimize antimicrobial use. So I just want to a little case study talking about that's the impact of antimicrobial intervention. This is just a scenario of a pharmacist that is really. So I was talking about the impact of antimicrobial stewardship intervention. It's case, but I'm looking at this scenario where a pharmacist is reviewing medication requests in the intensive care unit, and he noticed a trend of increased use of meropenem at a higher dose and also cholesterol. And when I was talking about the WHO aware classification, I did mention that these two drugs are the reserve list, meaning that they should be used at the last resort. In the intensive care unit, there is temptation, especially when the patient is not conscious, the patient is not talking, and especially when the patient has been brought in by somebody that does not even know the patient, maybe an accident victim due to traumatic brain injury. Patient is now there. So maybe nobody to communicate with, to even ask of the medication history, the past medication and all that. You'll be directed to give based on experience. But we are looking at this. Okay, so what will the pharmacist do? The potential action to do is to conduct an antimicrobial stewardship review, assess the appropriateness of meropenem and use. Consider factors like the infection type, the microbial susceptibility, and the patient-specific factor. I didn't mention it. In the intensive care unit, it may not be that easy for you to just get all the details about how the patient, especially if it's an accident victim. Probably somebody who has helped to bring the person to the hospital. So the follow up to the other healthcare team, like I said, we don't want to discuss findings within the usage aligns with us. So we want to review the hospital antimicrobial guidelines. We want to ensure that the guidelines are up to date and it reflects current evidence base. We know now these days we want to track it and inform strategy for optimization, implement intervention like dose optimization, de-escalation, or alternative therapy in order to promote responsible antimicrobial use. These are the goals the pharmacist should look out for. Because you want to promote effective treatments, you also want to minimize antimicrobial resistance. So everything that pharmacist is doing should be tailored to that. They want to reduce adverse effects. They want to optimize patient outcome because we want to improve the patient quality of life. We want the patient to get better. So we do everything to ensure that one is done. I just have a few recommendations, although it's for my facility. Not for yours. I know over there, they are doing pretty well, I can say. We want to establish a multidisciplinary antimicrobial stewardship by assembling a team of healthcare professionals, including physicians, pharmacists, microbiologists, infectious control specialists to oversee the antimicrobial initiative. Now, the microbiologists are very important in this team because they carry out these tests most times. So we really need to interact with them, find out the available drugs that we have. If they can help us to see if they have kits to carry out sensitivity tests for them. So that it's not all cases we need to tell them to go out. We also want to provide regular education and training. We want to offer ongoing education and training for healthcare professionals on best practices in antimicrobial stewardship. And we want to monitor antimicrobial use and provide feedback. Providing feedback is very important because that will make our track if there's an issue. Then tracking antimicrobial use and provide feedback, not just to the prescriber to promote responsible use and to optimize patient care. In conclusion, I will say that effective antimicrobial stewardship requires a collaborative effort among healthcare professionals. It's not just one single healthcare giver that can handle it. And by implementing best practices, we can optimize patient care, we can reduce antimicrobial resistance, and we can also improve outcomes. So working together will help to promote responsible antimicrobial use and to project public health. Thank you.
Thank you so much, Dr. Timipre. So I'm going to go ahead and open it up for discussion and questions. I see a question in the chat from Mary. She asks, can you share alternatives to AMS so doctor and patient can use AMS less and use other alternatives more? Let's take UTI, for example. What non-AMS recommendations do you have?
Yep, thank you so much for that question. For UTI, that's the urinary tract infection, we have some of them that are syndromic, the kind of discharge that should be out, the color and then all that. So based on experience, some persons can just give. But even with UTI, I still recommend that patients should opt for the MCS. The MCS should be done. Let's see the organisms that are actually sensitive. Let's see the organisms that are actually resistant. So that we don't just use medications that will now turn out to be unnecessary. And that's the drug therapy problem. With me, I have my colleagues are here with me, representing my head of department. I have pharmacist, is the Elias, work together. Then I also have Dr. Maureen Okeroghene. She's here with me. They are public health pharmacists, and then this whole thing is just under their purview. I'm a clinical pharmacist, and then I work with them. So the questions we are expecting, and they will also help me answering them. Thank you.
Thank you. So I see Aghogho Outreach raise their hand. Do you have a question? So I'll see somebody raising their hand, and you could just hop in and mute yourself and speak if you have a question.
Okay, I have a question.
Yes,
I was not able to hear the response about what's an alternative for a UTI if you don't want to use AMS. And I couldn't quite hear it. Can you write it in the response, or could you just say it again? What is it you use for UTI instead of the antimicrobiotics?
Okay, I think he's talking about the issue of resistance, which we're trying to avoid here. You know, the issue of antimicrobial stewardship is it's everyone's efforts in ensuring that we don't have issue of resistant organisms in circulation. Of course, we know the impact of resistant organisms, the issue of longer stay in hospital, mobility and all, and mortality arising from the use of resistance. What we said was that issue, people need to go through MCS, try to look at the system of antimicrobials that this organism will respond to before initiating somebody in antimicrobials, if there is no emergency. But for this situation, of course, we can actually treat empirically.
yeah, that is treating empirically. That's treating empirically because it's not you're not using the antimicrobial. Yeah, I mean, you're not using MCS. But we just mentioned that we are encouraging. We don't even want an alternative. We want a situation whereby it's done. Is it an emergency? Otherwise, it would have been better to do the.
Thank you.
So I saw somebody else raise their hand. I think it was Aghogho Outreach, the FMC Yeneway from Aghogho Outreach. If you have a question, please unmute yourself. So you mentioned earlier that a key component. Oh, sorry. So I see that they're speaking now.
Can you hear me?
Yes, I can hear you.
Well done, pharmacists. Thank you so much for this presentation. I just wanted to, I want to applaud you for using a multidisciplinary team for your stewardship. I just want you to clarify how you involve with the laboratory scientists in your antimicrobial stewardship. Because I heard you when you mentioned that usually work with doctors and ask them, tell them, inform them about the medication they're using or the need to maybe change the dose or change from parenteral to oral. So how do you do that in the laboratory? What would you do in the laboratory when it comes to AMS? Thanks you.
Thank you. Somebody wants.
I think I want to answer that question. It all boils down to what was presented. Stephen mentioned about microbiologists. I think she was actually referring to medical arthritis, because of course in the hospital, we did directly with medical arthritis, yes. Of course, in medical arthritis, we have the microbiologist aspect of the life science. So we are referring to medical arthritis when it comes to the issue of microbiologists. Thank you.
Okay, yeah. Dr. Maureen, you have
Can
something.
I also add something to that? The concept of having all professionals work together. We are working towards it and developing that. It's a gradual process. We want everybody to be involved. These are the key professionals that we desire that should be on this team and make it effective. So gradually, we're still like working on a framework where each and every one of them be involved in ensuring these our policies are effective in this setting. Thank you.
Thank you. I see a question in the chat. So in a situation of territorial divide among health professionals, how will it bring the professionals together?
it is not, like I said before, it's not going to be easy, especially when it's a program, antimicrobial stewardship is a coordinated program. And what makes it easier is leadership commitment from the management of the facility that wants it. Now, there was a time I really did something on antimicrobial stewardship, going around all the units. We have several units here in the Federal Medical Center here in Aghogho, the different pharmacy units, and I concentrated more on patients that are on admission. That are talking about the inpatients. Then going around each unit to find out the medications they are taking, was MCS done for them? Did they just start? And if later when it was done, was there a switch? Then even after the patient is stable and all that, is there still a switch with me from IV to? We had a lot of challenges. And then going to some other, working with the medical lab has not been easy either. Because not just one person, you have to meet several persons in order to, especially the HOD, the head of department. That's why I was advocating. I said, in order for it to be successful and for it to come out well, the collaborative efforts has to come, and that's to involve some key persons in this team in order to make it work. And like we've said before, it's not for individual interest. It's not for the interest of any particular healthcare professional. It's it's for the patient interest, because we want an outcome that will yield positive for that patient. And we don't want the patient to still remain the way the patient has come in. Patient to go home, improve their quality of life. So it has been challenging. That's just the truth. All these things I'm saying, I'm just trying to let you know it has been challenging. But I know that if there is a committee set up, or maybe there's something that exists, I know we have an infectious disease here. If there's something, I know definitely that it will be smooth. It will be smooth.
Thank you. So I have a question as well. So you mentioned that a key component of AMS is monitoring and feedback. In a non-emergency setting, how can we ensure that outpatients are taking their antibiotics correctly at home, like patients in outpatient setting? Just because it's like easy to forget a dose, and sometimes patient might use it incorrectly, double up on antibiotics. How do we like ensure that they're using it correctly? Should we use like medication diaries, or maybe use an app? Just basically, what system do you guys recommend?
Okay, I think what it is based important here, another issue of patient education. I will need to actually, for patient, of course, we can work on them because they are there in the world. But for black patients, of course, those ones, they require patient education, patient education. When you talk about the issue of antimicrobial stewardship, you're also looking at the prescriber, you're looking at the pharmacist, you're looking at the end user. When there is no issue of non-adherence, that will constitute the issue with the antimicrobial resistance. If we don't educate patients that when you define medication, they need to adhere to these drugs or medicines, then we have an issue for the patient constitute the issue of antimicrobial resistance or an issue of non-adherence. So we have a role to play, particularly with pharmacists, in educating the patients on the role they have to play in ensuring that antibiotics are not messed up. Because this will affect every one of us, whether we are patients or not patients. But at the end of the day, when these resistance machines are transferred from one person to the other, even you and I can also be affected. Thank you.
Thank you. I see Dr. Otto raise his hand. Do you have a question?
Oh, yes. Thank you so much, the presenter, Doctor, for that wonderful presentation. Hope you can hear me. Please confirm that you can hear me. Okay, yes. David, I'm joining in from Uganda, Kampala, Uganda. My question is, do you have guidelines on prescription of antibiotics in Nigeria? For an example, in my country, there are high-end antibiotics. For example, meropenem is not prescribed unless you have a culture and sensitivity result to back up your prescription. But from nowhere, you can't just prescribe it. That has been done as a way of controlling abuse of antimicrobial in my country. Does the same apply in Nigeria? Thank you so much, and a good evening to you all.
Yeah, in fact, I'm very impressed to hear that down there at Uganda, you can't just prescribe like that. Sadly, here, over here, it's not like that. The guidelines are there. They are seeing it. It's not as if it's not there. But the prescription is flying around. That's just the truth. So we really don't have, these are the reasons why we are thinking that we need to set up, I don't know, even if it's not looking into it to implement some policies to help us with a kind of protocol to help us we should have a guideline. It's not like anybody can really just buy meropenem over the counter here in Nigeria. Yes, in Nigeria, yeah. So it's not like that. So I really want to commend your country. It's nice hearing that.
Okay, any other questions?
Yes. I have another question.
Go ahead, Mary.
Reverend Dr. T made a good point about the territorial divide. How are we going to bring healthcare professionals together? And I'm looking at these 20 names and faces on the screen right here. What about if Global Offsite Care Grand Rounds is a place where we can ask everybody to just say, for example, what do you do in your country as an alternative to, for example, I have UTIs. And if everyone could just put down what they use, we have a fabulous source of information in 1 second, rather than this thing we have to follow up on. So anyway, would you be open to me trying that right now and saying, what would each of you use as the alternative to antibiotics, antimicrobiologics on a patient that had a UTI and you did not want to give the antimicrobiotic medicine?
But in Nigeria, we have a health guideline that forms on what to use for any this condition. We also have the hospital formulary, which will have a list of antibiotics or antimicrobials in general that we use, because the hospital has our hospital facility has a hospital formulary that informs the choice of antibiotics to be used for any condition. Thank you.
Like by now, what do the rest of you use? Aisha, in your pharmacy school, what do they recommend instead of antimicrobiotics?
Okay. It's my medical treatment. People can go for most places here. They use Cipro. They use fluoroquinolones. They go for fluoroquinolones, which of course we are saying that we should be able to start from the access group, because for what we said, we need to start from the access group before progressing to the wash group and lastly to the reserve group. Here, that's one of the reasons where we're advocating for this, so that people will know the needs to adhere to the antibiotic stewardship program and ensuring that the use is not abused. Because actually, what brings about the issue of antibiotic resistance is the issue of misuse. If the drug is being prescribed, the right drug being prescribed, or the right antibiotics are being prescribed for the right use, right condition, right nutrition, and all the right to have a rational drug use, end up not having the issue with the antibiotics or antimicrobial resistance. But the misuse of antibiotics by wrong prescription, by wrong administration, and by wrong use by the patient constitute the issue of antimicrobial resistance. And we all have to join hands in fighting this in the race, because it's a deal of public health per side. And we all need to put our hands on them to show that we eradicate the issue of antimicrobial resistance in our society.
Do any of the rest of you have 1 or 2 words I could write down about what you use as an alternative to antimicrobiotics? Like D-mannose, do you use D-mannose, do you use cranberry? What do you use?
If you have an answer to that question that Mary posed, you can go ahead and put that into the chat. I'll see another
one. First, I use that. Hello?
Yes,
Sorry,
thank you.
Yes, what I'm saying is that because of the chaotic situation pattern, and also because a lot of people, even though we have the guideline, but don't follow the guideline. Yeah. So in also situation where someone can use the cyclofloxacin or levofloxacin for a UTI, and a person can decide to go for other antibiotics, most of them for different specific parts. There's no pattern of different. So we need to harmonize and ensure that people follow the guideline. And doing that, you can also reduce the issue of antibiotics or antimicrobial resistance.
Okay, I want to say some hello. Can you hear me? I'm beginning to understand what she's saying. Your questions, you want to find out the alternative apart from antibiotics that we use for UTI.
Yeah.
Yes, that is not antibiotic. That is not a drug. Probably even not a drug. There's all kinds of things. I know that even just recently, I did some health and beauty thing on Oriflame. Somebody showed me a product. It's not a drug. It's just, and I think one of the active ingredients there was this cranberry. Just probably because it's acidic, I don't know, but the way you use it, you just apply to the place, and after 15 minutes, you can wash off. So people have different things that they use that is not antibiotic. Yes, I really don't know of much here now, but I know so many persons from the audience who have different experiences on it.
That's why it's great to have 20 of us. Like out of 20 people, how many different answers do we have?
Wow.
Thank you so much. I also saw that Dr. Ruby chimed in that in the U.S., most likely non-antibiotic would be like Azo or Peridium. And also, I see a question from Dr. T. Would you kindly provide your perspective in a situation where you are operating in a rural setting where sensitive tests are absent? What would you implement? How would you implement AMS in a rural setting?
Yes, because we've also mentioned that empirical use if it's not an emergency, but if it's not available in the rural setting, like you mentioned, if it's not available, then we even have cases where physicians give based on this one or two like that. It was good, and then they give based on experience, and they begin. And if there's access to NCS, then when they do, then they can switch. But if that doesn't happen, then they begin to do empirical treatment is not wrong. But what we are just saying is that it should not be just every time it's done and that just be the only, that's what we are saying. But in a place where there's access, like in an hospital setting like this, where we have all healthcare professionals together, it can be done, then can be achieved. Start.
You. I see Loibo, raise your hand. If you have a question, please unmute yourself.
Okay, good evening. What I wanted to contribute to this presentation, I want to appreciate pharmacist for the nice presentation. And the contribution is about the use of scent leaf for the management of UTI in the rural area and the lifestyle modification, such as drinking enough water. And it can also use cucumber. Eating enough cucumber can also help in the management of a UTI. Then there is a drink commonly used here this way. It's known as ginger. We also use it in the management of UTI to alkalize the system of the patient. So this is my contribution. Thank you.
Thank you.
Thank you so much. Thank you so much for my study.
Thank you. Does anyone else have any questions or anything you want to chime in? I think I had one more question. So again, like in an outpatient non-emergency setting. So what would you do in a situation where like a patient wants a specific antibiotic or is very adamant about getting a specific antibiotic? Because as a medical assistant before, I've seen situations where patients are like, I need amoxicillin for this. What would you say and how would you counsel the patient or what would you do in that kind of situation if that's not the right medication for them?
Okay, thank you so much. At this point, that's what my colleague mentioned previously about patient education. Patients can demand certain things because right now the world is, how do I say it? Everybody's becoming so aware. There's the internet. Some people self-prescribe. Some people diagnose their own signs and symptoms. So we really have to take a lot of time in educating that patient, because a lot of them can come with their prescription already in their head. So this is where we come in. We have to educate you, tell you, you don't do this. We start from access antibiotics. We start from this. If you have an NCS report, we show you the results of sensitivity. This is better for you. We now look at patient characteristics. You mentioned that if you're pregnant, we tell you this is not safe for you. If you're young, we tell you this is too strong for you. The education is paramount key. So I think if we can reach that gap and make them understand the safety and that antibiotics may look harmless, but they can be terrible agents. So if we can do that, educational counseling, I think we can communicate very well with the difficult patients. Thank you.
Thank you. All right. Does anyone have any more questions? I will go ahead and wrap the meeting.
Oh, wait, one more question.
Yeah, go for it.
How many of you are going to the Calgary Rotary International Convention where we're going to have the telemedicine booth? Or how many of you are going to be there?
Okay, good everyone. Good evening, everyone. Hope I'm audible.
Yes, you are.
Listen.
Just want to appreciate my dear colleague, Dr. Timipre, for an excellent presentation. I listened all the way from UNTH Enugu. That's a very good one. My center will practice antibiotic stewardship and is working for us. Really, it's a collaborative effort of the healthcare professionals involved. And I can tell that we are getting a very good outcome. I work in intensive care unit. It's highly challenging there. As she said, before you know it, you see problem in the prescription because having looked at the patient so critically ill, having running temperature, everything is wayward. But still, we try our best to get it right, and we are getting a very good outcome. Okay, I just want to portray this, that after all said and done, after good diagnosis, after you want to do the right thing, the correct guideline, but you don't give your patient the quality medicine, quality antibiotics, our efforts will come back to zero. So it's very imperative that the pharmacists must have a good quality control lab in their institution so that you are sure that your antibiotics is at the right dose, it's not substandard. So whenever you give it out to your patients, you get the good results. Not that there is a resistance strain or something like that. Why? Because the medication may be substandard. So let's just look into that one too, to be sure that we make use of standard antibiotics that went through good quality control by the pharmacists. Thank you so much.
Thank you.
Wow, thank you.
Thank you so much. That's a wonderful contribution by pharmacist Uwafo Mori.
Thank you, Ma. We appreciate your contribution.
Thank you. All right. So is there anything else? Anyone would like to add any question?
One more question.
Yeah.
Can you ask Dr. Smith what they use in the Bahamas for UTIs?
Yeah, we tend to use drugs like Bactrim, nitrofurantoin, Cipro.
Are those antibiotic micros?
Yes, yeah, antibiotics.
What do you use for natural cures?
There's some bush medicine, but they also stuff like cranberry juice.
Oh, yeah.
Basically.
Okay.
Yeah.
Oh, great. Thank you. Thank you so much.
No problem.
Thank you, Rary. Okay, thank you, everyone. So we're coming to conclude. So thank you so much, Dr. Timipre and your team for this insightful presentation. It was amazing. We learned so much today. Thank you very much. This recording is going to be uploaded to our YouTube channel in a couple of days. And as a last reminder, you can use the links that I provided in the chat to create a Figure One account. If you're interested, please sign up to receive our monthly Global Grand Rounds invitations. And if you're also interested in presenting, you can go ahead and email me. My email is in the chat. Our next Global Grand Rounds is going to be the second Wednesday of July. And as always, we appreciate your participation and continued interest in Global Grand Rounds. And have a great day. Thank you so much for coming.
Oh, Aisha, while you're still on, what do you recommend for a natural solution for UTIs?
So I don't really know much except the cranberry juice, just from, what everyone is saying. I think that is a good thing. And also like azo as well. And I don't think that's not an antimicrobial.
No, that's over the counter. You get that over the counter. In all these nursing homes, California, we have tons of nursing homes, and people get UTIs a lot, and they're just starting to give all of them these antibiotic whatever I can't get that word straight. It's just easier. So they have them on it regularly and take a little bit every day. It's terrible.
Yeah.
And they need to find an alternative. And that could become your specialty, Aisha. If you could figure an alternative. Because if you're like, if my mom is there, I don't want her to just be on that heavy medication every day.
Right.
If you're running a nursing home and you have 1,000 people and you want them to just be quiet, okay, that's one thing. But if you love somebody with the UTI that's older, you want an alternative.